All right, everyone. Good afternoon. My name's Kevin. I'm one of the cardiology fellows at Morningside. I'm sure I've met many of you. Today, I was invited to discuss a very important topic that is also very complex, and that is wide complex tachycardias. So I want you to know that the purpose of this talk is not for you to master the topic by any means, but rather just to get a strong foundation on which you can make some better clinical decisions during emergencies. So I'll start with a case, and this is very similar to consults we get overnight. So we have a 78-year-old male with a past medical history of ischemic cardiomyopathy. EF is 20%, with RV failure, a history of coronary disease with a CABG, and paroxysmal AFib. The patient comes into the ED with dizziness that started 1 hour prior to arrival. Looking at the vitals, the patient's afebrile, the heart rate's around 150, the blood pressure is low normal around 95/70. He's a little bit tachypnic with a respiratory rate of 30. On physical exam, the patient's alert but appears fatigued and no acute distress. Heart exam is tachycardic and regular. There's no murmurs. There's rales in the lungs bilaterally and mild pitting edema with lukewarm extremities. Labs are pending. And this is the initial EKG that's presented by the ED team. So would any brave souls out there like to read this EKG, not necessarily in detail, but just describing what you see? Anybody?
Take a stab at it. We'll help you along the way. So if anybody wants to start, we can guide you along the way.
I guess I can try.
Go ahead, Kruti.
Go for it.
Okay, so I would start with the rate, I guess, and rhythm. I think this is, sorry, 1 second. Like 150s. We already know what the heart rate is, so I'm guessing like I do 300 by the number of boxes.
Yeah, exactly.
So, yeah, and then I would be regular or irregular. I think I cannot necessarily appreciate P waves, or maybe there are the ones that are down trending. So then this would be like regular tachycardia.
Yep.
And
would you describe it as narrow or wide?
Wide. I think this would be wide complex based on QRS greater than 120. And the bleeds V1, V2. Yeah.
Perfect. And would you say all the complexes look fairly similar?
From like precordial, yes, they do to me.
Right. So yeah, whenever you see an EKG like this, you described it perfectly. So it's a regular wide complex tachycardia. The most challenging part is actually determining the rhythm. So whenever you see these, don't necessarily obsess over what the rhythm is, but when you're presented with these EKGs, that's a perfect way to describe it, a regular wide complex tachycardia. One of your differentials is ventricular tachycardia, but there's a variety of other differentials as well. So some of the key things before you even see the patient, this is an elderly patient. They have an extensive cardiac history, including low EF, history of coronary disease, and a prior history of arrhythmia. In terms of the vitals, the patient's obviously tachycardic. The blood pressure is low normal. And on exam, the patient is still alert. There are no distress, but maybe there's some signs of decompensation. The patient has rales, some pitting edema, and has lukewarm extremities. So when you're presented with a patient like this, what are some thoughts about what you would do next, or what's your general approach to the patient? And there's no right or wrong answers, but just pretend, this is a rapid response or anything else. You come into the room, you have limited information, and you're kind of required to make a decision pretty quickly.
I guess I would compare to a baseline EKG first to know if this is like, I don't know what we're thinking as if wide complex is ventricular versus is it an SVT with labor, and see if they have like baseline bundle branch blocks or something, and
Right.
that's how QRS looks.
Great.
Although if they're hemodynamically unstable and tachycardia, I guess you would, I don't know, cardio.
Yeah. So, always fall back on your ABCs, the patient's protecting their airway, they're alert. Circulation wise, even though they're currently somewhat stable, you don't really know which direction they're going to be headed. They still have a pulse, so you're not going to go down ACLS quite yet. Any other ideas, anything you would do in the meantime?
I'd probably put pads on them. Just
Great.
in case.
Yeah, absolutely. Great. What else?
I would also have, sorry.
Go ahead.
Sorry, I would try to, if the code cart's around, like have amio in case, in this case, he's hemodynamically unstable, so you would do unsynchronized cardioversion, but if he does stabilize or he breaks out, you can also have amio on standby as well.
Got it. Great. Yeah, and you guys are actually mentioning some of the things people forget, which are really the common sense things. Make sure there's good IV access, make sure you have emergency meds at standby, make sure the pads are on the patient. Once you do all those things, you buy yourself a little bit of time to actually figure out what's going on. So we'll kind of come back to this case in a little bit once we get a little bit of more information. So discussing wide complex tachycardias, how do we define them? So most of the time we just eyeball the QRS, but strictly speaking, it's a wide QRS greater than 120 milliseconds. So that's 3 small boxes, and anything with a rate over 100 beats per minute is considered tachycardia. So ventricular tachycardia is by far the most commonly encountered wide complex tachycardia, especially in patients with structural heart disease. This includes a history of MI or CHF. The likelihood of a wide complex tachycardia being VT is greater than 90% when the patient has a history of MI or any other structural heart disease. Which is pretty shocking. It's basically a giveaway to the diagnosis 9 times out of 10. Aside from that, there are a lot of other arrhythmias, such as supraventricular arrhythmias that can have similar patterns, and we'll go through some of those things. These are rarely asymptomatic, no matter what the actual cause is. It can be very dramatic symptoms or a lot of non-specific findings. So this ranges from cardiac arrest, syncope, chest pain, to vague symptoms like palpitation, shortness of breath, dizziness, and fatigue. In terms of hemodynamics, these patients can be stable or unstable. Just recently, I had a 30-year-old guy. He literally walked into the emergency room in VT, and it took about 4 to 5 hours before the ED actually discovered he was in VT. So, we like to make it sound dramatic, but it can be very, very subtle. And these EKG findings are not always clear cut, especially if you have an alert patient sitting in front of you. In regards to the physical exam, you can see varying levels of consciousness. You could have somnolent patients, they could be obtunded. Your cardiac exam, they're obviously tachycardic, which can be regular or irregular. They may have murmurs. You should always look for evidence of an ICD or pacemaker. You can have a variable S1 or S2, depending on the changes in hemodynamics and flow. Canon A waves, which I'll be honest, it's extremely difficult to pick up, but it's just one of the markers on the jugular venous pulsation that suggests that there's some sort of dissociation between the atrium and the ventricle. Always look for a sternotomy scar, which would suggest they had a prior CABG or valve surgery. The pulmonary exam, rales, respiratory distress, and overall their extremities are their signs that they're hypoperfused. So these are just kind of the main things you pay attention to when you approach these patients. Stable, unstable. You obviously try to determine the cause if there's something obvious. You want to know, is there any underlying structural heart disease, any offending medications or metabolic derangements? Important point, a normal blood pressure does not in any way rule out VT. Obviously, most of the time, these patients will eventually become hypotensive, but does not necessarily mean it's not VT. And a few basic rules. So treating a VT as an SVT can be harmful, but the reverse is not always true. So the safest thing you can always do is assume it's VT until you've proven otherwise. And other important things, as I mentioned, the history of heart disease has a very high predictive value for VT. Any prior arrhythmia, presence of an ICD or pacemaker, age, any family history of sudden death, and any offending meds. This can include antiarrhythmics, antibiotics, antifungals, various other medications as well. So, in academic medicine, when we encounter these wide complexes, we're always taught you have to determine if it's ventricular or supraventricular. And this is ingrained in our brain, but likely the single most important thing you can take away from today's talk is that it's not your primary goal. So whenever you see these patients, a million thoughts are going through your head. Always fall back on the basics. Does the patient have a pulse? No, start ACLS. Is the patient truly unstable? If the answer is yes, then you basically proceed with cardioverting or defibrillating or ACLS. So we'll start with a quick case. You're working overnight. You have a 72-year-old female, no clear medical history, admitted to the medical ICU with severe COVID pneumonia. She's intubated and sedated, not requiring any vasopressors. And she goes into the rhythm below several times. Each time it spontaneously terminates after about 30 seconds. So I'll kind of open it up again. What are some of your thoughts about, what's this rhythm? What is your initial workup going to be? And, the nurses are going to want to know, do I need to put in any orders? What do you want me to do? So anyone have any ideas?
A couple of people in the chat are calling it, Shirel and Kruti are saying it's non-sustained VT. Do you want to talk about workup first, or?
Sure. So yeah, you're seeing a very regular monomorphic VT. It's lasting about 30 seconds and terminating. So yeah, just basically, if you're alone, what are you going to do in this situation? Assuming there's pads on the patient, they have IV access. Yeah, what are you going to do to work this up? And are you going to order anything else?
I guess one of the things I want to make sure, like she's a sick patient, I want to make sure her lights are okay, because that's one of the things which can be reversed. Before moving forward, I want to take a look at the labs. Right.
Absolutely. So yeah, looking for any metabolic derangements, electrolytes, severe acidosis, alkalosis. Those are great thoughts. Anything else?
Also got a 12-lead EKG.
Absolutely. So anytime you get anything on telemetry, you always confirm with an EKG, no matter what. So that's always a great answer. What else? So would you order anything in terms of medications?
Do we have the vitals for him? Because I think we need to see, like, is the patient stable or not?
Yeah, so let's say every time this terminates, the patient is stable, not on pressors, and basically goes back into a sinus rhythm at like 90. So everything overall hemodynamically is otherwise okay.
I would say that start the patient. I think someone mentioned on the chat they also start amio for him. But otherwise, if it's less than 30 seconds, then I think it's kind of weird because it's at 30 seconds. But
yeah,
it's determining whether it's sustained or non-sustained VT.
Right.
Yeah.
Right. And yeah, all great thoughts. So there's no exact answers here, but basically in terms of meds in this situation, I would consider something like amiodarone. It's very commonly a first-line antiarrhythmic when patients are having these recurrent episodes of VT. Obviously, have pads on the patient. You want to work up why this is actually happening. So metabolic derangements, electrolytes, ischemia, so cardiac enzymes, if the patient's intubated. You would obviously want to touch base with cardiology, consider an echo. There's really a very wide differential, and you kind of treat it similar to sinus tach. You always want to look for the underlying process that is actually driving it. And here we see our ACLS algorithm. This is out of AHA from 2016. So I'll just kind of very quickly go through this. So basically, this is tachycardia with a pulse. So we're not immediately shocking. We have persistent tachyarrhythmia causing any of the following. So hypotension, altered mental status, chest pain, CHF, so forth. So if you answer yes to these things, it's saying you basically consider cardioversion, which can be either synchronized or asynchronous, which is also known as defibrillation. Whereas if you go down this route and it's actually a wide complex, you can consider different antiarrhythmics. These can include procainamide, amiodarone, and sotalol. And I've kind of just outlined the things they mention. So procainamide, you avoid if QT is long or CHF, and sotalol, you avoid if QT is long. So this is often why we go with amiodarone. It's a very well-tolerated medication, so it's kind of our first line in these scenarios. And one thing I just want to point out, some of these things are very subjective. You know, a patient with mild chest discomfort, I might not necessarily jump into shocking immediately. I think when they say these things, they mean it more dramatically. So it's really the patient who's screaming in chest pain, the patient who's in florid heart failure, because a lot of planning actually goes into cardioverting a patient beyond just pressing the button, especially if they're alert and non-intubated. So just understanding why the QRS is wide is important. So essentially, it's just a marker of any abnormal depolarization of the ventricle. So our normal pattern of depolarization, I won't go in detail, but the basic concept is in any lead, if there's a positive deflection, the impulse is going towards it. And if it's negative, it's going away. So this is our ventricular myocardium. You initially have this left to right. So assuming, let's say this is our lead 2, you'll have a small negative deflection. As it progresses towards the lead, you have a large positive. It continues in the direction of the lead, it completes its positive, and then the terminal portion of the LV, it's kind of going away from the lead. So you have this final negative deflection, and that forms our normal QRS complex. So our differentials for wide complex tachycardias include any supraventricular arrhythmia, meaning anything above the node. This could be sinus tach, ATAC, AFib, anything above the node with aberrant conduction. And just remember, aberrancy just means an atypical path to the ventricle. So this could include a patient with a bundle branch block. It could include patients with accessory pathways, such as Wolff-Parkinson-White. You could also have ventricular paced rhythms or rhythms actually originating from the ventricle. So I'll start with supraventricular tachycardias. So without going in too much detail, right bundle and left bundle branch blocks are essentially blocks in the normal conduction. So they each have a very typical pattern that we see. So if you could imagine any tachycardia that's going through an abnormal conduction system, so if the patient has a wide complex to begin with, a right bundle, then if they're at a fast rate, they're essentially going to have a wide complex tachycardia. So it's important to understand what a normal right and left bundle look like. I won't go through it now for the sake of time, but this is one of the ways we can actually distinguish between VT versus an SVT, if it fits the typical patterns or not. So in a right bundle, it's positive in V1, and you have this slurred pattern in V6. And for a left bundle, it's predominantly negative in V1 and predominantly positive in V6. And then there's a variation called left anterior and left posterior fascicular blocks. Very similar idea in that you're taking an abnormal pathway of depolarization. And there's something called a functional block where essentially at certain heart rates, some patients may actually develop a temporary block in the conduction system. And then they'll only conduct through an atypical pathway. So in essence, they like kind of create a right or left bundle pattern at certain heart rates. And you can see like in this situation, they go from a narrow sinus QRS, and then they suddenly have this wide complex. So we have a 38-year-old male, no medical history, who comes to the ED with near syncope and is found to be in the rhythm below. He's currently alert but somnolent, and his blood pressure is 100/80. So I'll, for sake of time, I'll kind of describe what we're seeing. We're seeing an irregular wide complex tachycardia. So the first question I'll present is the patient stable or unstable?
Kruti in the chat says unstable.
Yeah, so even though the blood pressure is okay, the patient's, kind of somnolent, especially at this heart rate, you can notice how fast it is. At times it's close to 300. So even though the patient's alert with a blood pressure, you anticipate he'll likely be crashing at any moment. So this is the type of patient I think you would proceed directly to shocking. So in this case, because it's irregular, you actually defibrillate the patient. When it's a regular wide complex, you do synchronized cardioversion. They're slightly different, but it's an important thing to differentiate between. In this case, this was a young patient with AFib and underlying Wolff-Parkinson-White. So this is one of those highly tested subjects on like USMLE. The key thing I want you to take away in these scenarios, procainamide is the drug of choice. And if you remember, that's in our ACLS. So anytime you encounter an irregular wide complex tachycardia, especially in a young patient, procainamide might be a good choice. The highly testable points, you avoid any AV nodal blocking agent, and I'll explain why in a moment. So Wolff-Parkinson-White is an accessory pathway. So normally you conduct here through the AV node. And in these patients, there's this accessory pathway on the side. So if you imagine for a second, if you knock out the AV node, everything will conduct through the accessory pathway. So this is dangerous because if these patients go into atrial fibrillation, basically if the atrial rate is 200, 300, 400, that could theoretically conduct into the ventricle. And that's the exact reason we don't give AV nodal blocking agents, because they will further knock out the AV node and you'll conduct completely through the accessory pathway. And I forgot to mention the delta wave itself, as I said before, it's due to abnormal depolarization because you're not going through the normal path, you're going through an unusual path. So that's why you essentially form this wide QRS with the delta wave. And this is just another variant called AVRT, where essentially similar idea where the patient will have a PVC, they'll form some sort of block, and then they will conduct through an unusual pathway. So similar process as Wolff-Parkinson-White. So next I'll discuss ventricular paced rhythms. So with newer intracardiac devices, you can have RV pacing. We have BiV pacing where you have an RV lead and a coronary sinus lead, which is the same as an LV lead. And basically you're depolarizing from the ventricle. So it makes sense that you would have a wide QRS because it's originating in the ventricle. So Key thing to remember, an RV paced beat looks like a left bundle. That's why it's negative in V1. And an LV paced beat looks like a right bundle, which is why it's positive in V1. So any ventricular paced rhythm can look like a wide complex tachycardia. That's the takeaway point. And I'll take care of this one for sake of time. 58-year-old admitted for cellulitis, has the EKG shown below. So it's a regular wide complex tachycardia. You can see the paced complexes here. And this is something called pacemaker mediated tachycardia. Really the takeaway point for you guys, anytime you see a paced rhythm that is consistently between 120 and 130 and never budges, this is probably the cause of the tachycardia. And it's due to a circuit within the pacemaker. And basically the treatment is to put a magnet over the device. Obviously touch base with cardiology first, but it's a very simple fix to break the cycle. And basically it happens because the RV lead is pacing something inappropriately in the atrium, and it starts to create this endless loop. And finally, for ventricular complexes, PVCs, any beats originating in the ventricle. So if there's one or two, it's called a PVC. If it's greater than or equal to 3, it's called non-sustained VT. And anything greater than 30 seconds or anything requiring intervention is called sustained VT. And this is just showing that depending on where the beats originate, the QRS will have different patterns. And this is a little beyond the scope, but we're actually able to determine based on the lead axis where the beats come from. So, you know, if it's, for example, if it's starting at the top of the heart and going to the bottom, you would expect the bottom leads to have a positive deflection. So you can actually localize where these things are coming from. And this is just a great diagram. It kind of highlights a lot of what we just went through. So regular rhythms, you think of SVTs with aberrant conduction or WPW. This is that other atypical pathway I mentioned, paced rhythms, and your last differential is VT. And on the other side of the algorithm, we have irregular rhythms such as VF, AFib with pre-excitation, which is WPW, or any aberrant conduction, and polymorphic VT, which comes in 2 flavors with either normal QT or long QT. So if anyone's overwhelmed yet, always fall back on the basics. So just always remember this if you remember nothing else. So you're the intern covering the CCU during the day, and your residents getting seamless for lunch. The nurse runs into the room and shows you the following telemetry strip for a patient admitted for NSTEMI. What would you do next? So can anyone tell me what they think this is?
Looks like ventricular fibrillation.
EFib, yeah.
VFib, all right. Anyone else?
The first thing I will do is to check the pulse.
Great.
So Joe, one of the interns in the chat, Joe Mel, says the patient could be moving.
Very good, very good. So yeah, so this is actually a case of artifact, but excellent first thought, VFib. Without knowing anything, you obviously want to quickly go see the patient, get an EKG, and then when you review the tele in detail, you can see that the QRSs actually do march out and that everything else is just all artifact. And I'll show you an example of how to actually figure out this is happening. So most of the time with tele, we have 2 strips. So always look at both, because often you'll see artifact on one, but when you look on the others, you may actually see a regular rhythm in between. And the same goes for EKGs. If you see the top here, it looks like it's some form of VT, but you look immediately below and you see that the patient has a regular narrow rhythm. So always look at multiple leads, whether you're on telemetry or an EKG, to confirm whether something is real or not. And now for VT. So it comes in many flavors. There's monomorphic VT, everything looks similar. Polymorphic, where they all look different. There is something called torsades, which is a specific type of polymorphic VT, but you only call it this when the QT is prolonged. So if the patient has a normal QT and goes into this rhythm, you do not call it torsades, you just call it polymorphic VT. And this is just showing that a PVC here is triggering the whole episode of polymorphic VT. And they had a few PVCs prior. And another example, you have this cool pattern of something called bidirectional VT, where it's basically alternating ventricular beats. This isn't something with dig toxicity, or something with, it's called catecholinergic polymorphic VT. Basically, the patients exercise and go into this. You don't need to know it, just thought it would be nice for you to see it. RVOT VT is another form, not really relevant to all of you at this time. And so one teaching point I just want you guys to know is how to describe something when you see it. So if you're calling us for a consult and you saw this strip on telly, knowing what you know now, you could describe this as either 6 beats of a regular wide complex tachycardia or 6 beats of non-sustained VT. And that paints a much better picture than, the patient went into VT. At least when you say this, we have a very clear idea of what exactly happened. And I'm gonna very quickly go through these things because we only have a few minutes left, but some of the differentiating features of VT, a northwest axis, things called fusion and capture beats, concordance, and dissociation. I'll show you very quick examples. So normal depolarization is from left to right, and in the opposite direction is this. So anytime you have a northwest axis, that's suggestive of VT. So here you see it's negative in 1, 2, and AVF, so northwest axis. And these things called fusion and capture beats. So a fusion beat is basically a combination of the atrial beat and the ventricular beat. It forms a different looking QRS. And a capture beat is when randomly you get normal depolarization in between the VT. So if you ever see unusual beats between the VT episodes, that suggests that it probably is VT. And concordance is essentially all the precordial leads being either all positive, like shown here, or all negative, like shown here. And AV dissociation just means the atrium and ventricle are beating completely independent of one another. Pretend there's a wall in between the two. So occasionally you'll see P waves, you may or may not. Sometimes we hallucinate them, but you can see that the QRSs are marching out nicely and you have these random blips that might be P waves. And I'm going to just skip through these for sake of time. These are just various algorithms. They all have very good specificity, not so much sensitivity, but extremely complex. And honestly, we rarely use them. Always have to look them up and they're very hard to memorize. So I'm going to quickly skim through those for now. So just going back to that patient we discussed earlier, the gentleman who had the CAD cabbage and came in. So knowing a little bit about what we know now, this patient was currently stable, but things we would anticipate are that eventually he'll become unstable. So eventually we'll get shocked, but in the meantime, he's alert. So getting emergency meds ready, getting pads on the patient, you're obviously going to want to give sedation. So I think it's always a good idea to have anesthesia standby for the whole process. So you give them a heads up, you get all your emergency meds ready, you get fentanyl, Versed, everything. And when everyone's ready to go, then you can actually proceed with shocking the patient. And in this scenario, would ultimately give amiodarone in the meantime. And assuming all turns out well, he would definitely go to the CCU afterwards and would need an evaluation for a defibrillator. And I'm going to just skip these just because we only have a minute or two left, and I want to show you guys some of the key takeaway points for today. So always assume it's VT unless proven otherwise. And even after 2 years of doing cardiology, I can tell you we sit in the rooms with multiple EP attendings and we argue for an hour straight about is it VT or is it not VT. It's not as clear cut as we like it to be. So just assume it's VT, especially if the patient has a history of CAD or CHF. Remember that has a 90% predictive likelihood of VT. If you know nothing else, just know ACLS. Amiodarone generally is our drug of choice when VT is suspected. Always compared to a baseline EKG. Unique exceptions to everything. Wolf Parkinson White, procainamide's your first choice. For long QT with torsades, you treat with magnesium. This can include IV mag pushes, but also a magnesium infusion. For pacemaker mediated tachycardia, call EP, we'll put a magnet on it. Artifact can look like VT. So if you see this, always look at other leads, always look at the EKG and see if you could confirm if you're seeing any QRS complexes. And, for internists and, I guess non-internal medicine people in the audience, refer to wide complex tachycardias with specific terminology. We don't expect you to make a diagnosis, but just describe what you see. So sustained, non-sustained, monomorphic, polymorphic, and importantly, does a patient have structural heart disease, history of MI or CHF? Things you always want to be aware of. Does the patient have any reason to need an ICD? And obviously never hesitate to contact cardiology with any questions or concerns. These are very complex things, even for us. But hopefully today at least gave you a little bit of guidance for how to approach, the undifferentiated patient. Thank you so much.
Thank you so much, Kevin. Any questions from anybody in the audience?
And I apologize for speeding through it. I know it's a very dense topic, but I just wanted to get across some of the main points.
Absolutely.
I just feel like something that I came up maybe like once or twice already. It's like, for some reason, we don't do any like related to amiodarone on the floors.
Right.
So like, I do feel like there's like a barrier for starting amiodarone. You have a patient, you call Rabii, or like a patient coming from like the ED, and then like it's like the patient needs to be in the ICU. So like they screen them, and sometimes they screen out, and then like I feel like you're kind of like standing in the middle of like what would be like a good next right, kind of like,
so yeah, anytime you're obviously prescribing any medicine, it's kind of a risk benefit. So if you get these patients, you're not sure what the rhythm is, you always want to know, is there an urgency to give this medication without knowing necessarily what it is? So if a patient has a short run of a wide complex thing on tele, you may have time to figure out what it is before you go give amiodarone or something. But there's other times where, the patients in the ED had a 5-minute episode of VT. And, as a specialist, I would be fine giving amiodarone, but I completely understand that many people would not necessarily be comfortable doing that. But, you can still have the medicine ready. You can have pads on the patient. You can do everything else. But, these are sick people. And yeah, there are times they should be managed in an ICU, even if the episode resolves. But, it's not an easy thing to manage, even though it can seem like it is.
I have a question. So I was in the ICU recently. We had a lot of cardiac arrest patients. The patient had an ICD. Yes. If they have an ICD and an RBBB at baseline, we thought that on tele, maybe having a sustained monomorphic VT. Right. Would we wait for the ICD to spike, or do we manage these?
That's a great, so you're saying if a patient with an ICD goes into like VT or VF, what do you do?
Yes.
Yeah. In theory, their device should fire. There's a certain time cutoff. So their devices can be programmed to say like 30 seconds of VT or whatever. With that said, don't overthink it. If you get there first, shock the patient with pads. Just know that if you see their chest bounce again or something, that their own device will fire too. But you can still shock a patient, even those that have a defibrillator.
Okay, and if they interrogate the ICD and it says no events, does that definitively mean that an arrhythmia was not the cause for the patient to go into arrest?
So if you think it was VT that you saw in telemetry, we can definitively tell if it was VT by interrogating the device. So if we check and we see that, no, this was not VT, it was AFib with a wide with something, then basically you've eliminated VT as your diagnosis.
Okay, thank you.
Sure.
I just had a question in terms of like distinguishing between VTs and also wide, I guess like supraventricular tachycardia with vibrancy.
Right.
How do you go about the process of distinguishing between the two? I think like AV dissociation isn't always so apparent. So I was wondering like what would be like your process in distinguishing that?
Yeah, so I just want to say it's extremely difficult. Like I said, there's times we'll sit in a room with the EKG with 10 people for an hour. Some people might see AV dissociation, others will say they don't. You know, kind of the things, AV dissociation, access, capture, fusion beats, you look for all these things, you may or may not see them. The next thing, compared to their prior EKG. So if the patient has a right bundle and you're seeing a right bundle pattern in the wide complex rhythm, it's probably some sort of SVT. You know, we have all these algorithms, they're all fairly good, but the takeaway point is always compare to prior, and just know that no matter what criteria you use, it can be extremely, extremely difficult. And that's even for EPs. Sometimes they may never for sure know, and it's just an educated guess as to what the rhythm is.
So would you just like assume that it's wide complex, treat it as though it were like preparing for VTAC, and then just have an expert consult to see if it isn't or not?
Yes, and remember,
Okay,
if the patient has a history of MI or CHF, meaning systolic heart failure, 9 times out of 10, at the minimum, it's going to be VT. So it's always a safe guess to say this is VT until proven otherwise, especially if it's a cardiac patient. Any other questions?